Hi, everyone. My name is Dr. Gail Roboz. I'm a professor of medicine and director of the leukemia program at Weill Cornell Medicine in the New York Presbyterian Hospital in New York City. Thank you again to the organizers for inviting me to be part of this excellent meeting. And this is a second talk that I was asked to give on the emerging role of real-world data in AML, which is an interesting topic because I guess the first thing we have to do is define the real world, which is kind of complicated. These are my disclosures. And I thought that this was maybe a sign from the internet that was describing what we're trying to do here. So it says, welcome to the real world, and the population is everyone but you. So I like to joke with our colleagues from MD Anderson that they certainly don't work in the real world. It's certainly not my real world, but everyone's real world is a little bit different. And when we're trying to talk about data, often what we mean here is what's happening in the office, what's happening in practice, what is happening to our patients at a particular center outside of clinical trials. But I think everybody has a slightly different understanding when they are seeing a paper, for example, that comes out about real world data about who might be included as those participants. The FDA actually has very specific definitions here. So real world data are data relating to patient health status and or the delivery of healthcare routinely collected from a variety of sources. Examples of real world data include data derived from electronic health records, medical claims data, data from product or disease registries, and data gathered from other sources such as digital health technologies that can inform on health status. This is taken directly from the FDA website. What they talk about for real-world evidence is the clinical evidence about the usage and potential benefits or risks of a medical product derived from an analysis of real-world data. So I think this gives a sense of what are we trying to do. But if you look here at what is cited specifically, how do you get access to this? Where are the electronic health records, medical claims data, data from products? Where are these data located? And I think if you think about the point of this talk, why are we even talking about this? There are significant potential applications of real-world evidence in AML that are emerging primarily because AML is a rare disease, fundamentally, tens of thousands of cases, not hundreds. And there are too many questions to ask and too many subtypes of AML to have randomized data for everything. It's simply impossible. We'd like to answer some clinical questions to help us out in clinic. What happens if you check MRD on older patients? Does it matter? Does it guide therapy? What's happening in transplants in one part of the world versus another? There are clinical questions that are helpful. There's the possibility to accelerate drug approval, again, in rare populations. There is the idea to confirm single center data. The MD Anderson pilots regimen after regimen after regimen that look amazing, but can other centers reproduce those data? Can we take the same protocol and try it elsewhere and get the same data? Can we create a synthetic control arm? What that would mean would be to take a whole bunch of patients, for example, across the world who are currently being treated with azacitidine and venetoclax, not the VIALE-A trial, but the current world. What do those data look like? And then randomize a new trial to what we would call a synthetic control. It's very difficult sometimes to get people to agree to randomization when there is a novel agent being tested. So if you had a believable control that's representative of what's going on in the field, you wouldn't have to ask patients to be randomized. What about insights into regional differences in care and outcomes? There are everything from access to supportive care, to practice patterns, to pharmacogenomic types of things that might result in different parts of patients from different parts of the world simply having different responses to therapy because of pharmacogenomic changes that we almost never look at. But we do know that if you're looking at Asia versus looking at Europe versus the parts of the United States, outcomes are different. And there are lots of different reasons that can go into that real world evidence can help us sort out. And I think that the problem here is that how do you pull all of this together? I can present my data and you can present yours and we can compare them, but how would we actually do this in a statistically sound way? What type of informed consent would be needed? Are patients signing paperwork that is allowing their data in electronic medical records to be looked at? Who's collecting the data? Who's actually doing this work? How are they aggregated across different centers? Is there some kind of giant spreadsheet of the universe that we would all dump our data into? Nice idea, but it doesn't exist. Where do they go? Who's housing them? Who's responsible for them? And who owns such data? If there's a giant red cap that we're all collecting data in, who has ownership of it? Who can publish those results? And of course, who's paying for all of this is a major question, because not many academic centers have a lot of extra cash lying around to do extra studies. But that said, I want to show you some of the things that we could try to be answering. So for example, who's ineligible for intensive chemotherapy? All of the AML slides that you're going to see are going to show intensively treated, low intensity, chemo ineligible, chemo eligible. Well, who says? Who's defining that? Even ASH came out with a statement that said the panel couldn't clearly define a patient population that was unfit for intensive chemotherapy. We all use the eyeball test. We take a look at the patient at the bed and see what they look like and see what they think they could handle. But how is this decision made, and how is it made all over the world, and how does this influence our practice guidelines? Well, we and other groups, this is ripped from an ASH presentation, this is led actually by my group at Cornell, tried to look at comparisons of liposomal daunorubicin and cytarabine, which is an intensive therapy, combined with azacitidine and venetoclax in frontline therapy in AML. These are retrospective data. This is what we called a real-world multi-center retrospective chart review. I don't know if you consider Memorial Sloan Kettering Cancer Center, Cornell, Northwestern, and Moffitt the real world. It depends. It's kind of the real world. But this was a headache to put together. We had to put lots of agreements in place to share the data, but we were looking at any patients, not just clinical trial patients, any patients who got CPX or who got HMA plus venetoclax, and we found 448 patients. And it took a while to pull together these data because, again, not everybody, when you're treating patients in clinic, you're not necessarily thinking about aggregating or categorizing your data in a way for analysis. But we pulled it all out, and we noticed some very interesting things. That most of the patients actually who were overlapping were between 60 and 75 years old, which is kind of what you would think. The younger patients had a strong bias to getting CPX. The older patients were generally getting HMA and venetoclax. But younger patients between 60 and 75, which is what most clinicians will talk to you about, well, that's a hard group. As a 65-year-old, they might be able to get CPX, they might be able to get HMA venetoclax. Which one is better, and how do you decide? Again, these are retrospective data, but it's starting to bring to light the point that there might be populations of patients for whom actually it doesn't matter which one of the therapies they get. There, in this group, there was no difference in overall survival looking at 60 to 75, whether they got CPX 351 or whether they got HMA and venetoclax. I'm not trying to tell you in this meeting that these are equivalent therapies. I'm just trying to show that if you look in the real world and see what's happening to patients, it's interesting, because you would think that this would be an absolutely incredibly important decision out of the gate, which one a patient should have. They're 68 years old, they have some comorbidities, which one could they of these therapies should they get? Well, it looks like the curves are superimposable. And if you look at this by ELN risk, too, it was actually fairly superimposable as well. And the manuscript actually for this presentation is under review, so you should be able to read this in print soon. If you look at multivariate analysis, there was no difference in overall survival in this group, despite more than double the rate of stem cell transplant in the CPX cohort. There was, whether you censored, whether you didn't censor for transplant, there was no change. There was a higher overall survival, interestingly, in the TP53 positive patients who were treated with CPX. And again, those patients had a higher proportion of going to transplant. Outcomes for TP53 are still not anywhere where we want them to be, but it looked better for CPX. And if you looked at whether it was prior malignancy, prior HMA, adverse ELN risk, it kind of looked the same. No difference from this selected population, real world data. Now, if you look in post-transplant, this also didn't seem to make a difference. So again, begging the question of what is transplant actually offering for these patients in the real world? And I'm going to talk a little bit about who actually gets a transplant in the real world of taking care of AML patients. Other groups started looking at this at the same time, and we have large data sets from Penn and from Moffitt in the United States, again, looking at basically superimposable survival curves of patients who were screened from EMRs, from electronic medical record data. These are not the patients who were treated in a randomized way in a clinical trial, but again, it looks like there was similar overall survival in all subgroups. There were benefits for transplant that were critical both for the HMA-VEN and for the CPX patients. If those patients, whichever one of those regimens they got, if they went on to transplant, you can see here on the right that the transplanted patients did better. But I think this is a very interesting way of looking at these data, and it's certainly thought-provoking for clinicians as they're trying to decide for a particular patient which therapy is the one to get. This is actually being called the survival of the fittest trial, which is looking in a randomized trial upfront of a hypomethylating agent and venetoclax versus intensive chemotherapy to see if we can see in a newly diagnosed upfront patients who are randomized, does it make a difference? And this trial has accrued very well, so hopefully we may be able to see some data soon. Now, also looking at treatment patterns in a real-world setting offers insights into what actually happens to patients with AML across private practice settings, across academic centers, across a variety of different settings in the United States. We're not very good at registries in the United States, but the Connect Myeloid Disease Registry, of which I have been on the steering committee for some years now, this actually was put together to try to look at some AML questions across different treatment settings. And we found in this real-world registry data, there were 261 patients who got into remission. And if you look at what happened to them, the ELN favorables were a small number. There were very few transplants there, but those patients had transplant only in relapse disease. But in the intermediate and adverse, and then in the ELN unknown categories, most of those patients actually didn't go to transplant, even though if you looked at them on paper by risk stratification, they probably should have. They got something. They got consolidation therapy. They got ongoing therapy with something. Some of them even got maintenance. Clinicians know that AML patients who are in intermediate and adverse risk need something to maintain remission, but a lot of those patients simply can't go to transplant. And if you look at the reasons why, again, in real world data, age, comorbidities, and then there were lots of other reasons. Maybe they weren't in remission, poor performance status. I think that in the other category, lots of us have examples of why patients can't effectively go on to transplant. They don't have family supports. They don't have financial supports. Most patients have donors, but many transplant centers only do sibling related transplants. So there are lots of reasons why people may not get a transplant. And I think these real world data, and we are digging into this registry data, are helpful in understanding what patients' experiences outside of major centers and outside of sort of limitless access to transplant. When we looked at Quasar, for example, the Quasar trial was looking at oral azacitidine versus placebo in patients who couldn't go on to transplant. Now, these aren't real world data, but they are showing in this randomized trial that patients who couldn't get a transplant did better with maintenance. But But how do we know what to do? If I'm getting you to 2 years and 3 years, and even some patients getting to 5 years, how am I going to figure out if you have a 70-year-old patient? Well, are they better off getting oral azacitidine? Are they better off getting a transplant? The transplant data look difficult. These are locations also where actually finding out what happens to patients in the real world is important, because we are very unlikely to be able to do these randomized trials successfully. Here, you know from Quasar, again, from clinical trial data, you know that patients have, with NPM1 mutations and with FLT3 mutations, still benefited from oral azacitidine. But what about menin inhibitors? What about FLT3 inhibitors? What about transplant for these patients? We're never going to be able to do multiple randomized trials for every single patient who's in a 60 to 75-year-old category who could get some kind of maintenance, but they also could get a transplant. These aren't randomized trials. We're going to need to know what doctors are doing for these patients. Are they getting maintenance? Are they getting a FLT3 inhibitor? Are they getting oral azacitidine? Are they going to a transplant? These are the kinds of clinical questions that I get called about every single day of the week, and we're never going to be able to have prospective trials for all of these subgroups to answer them. In particular, we know, for example, that there are adverse events with oral azacitidine. You have a 68-year-old, you're trying to decide whether or not to do a transplant on that patient. Well, there's nausea, there's vomiting, there's diarrhea, there are things that happen with oral azacitidine, but you're weighing this type of adverse event profile to what could happen to them with transplant. These patients had a very good quality of life with oral azacitidine. What would your patient's quality of life be like with a transplant? How are you going to see into the future to assess this? And not only that, it gets even more complicated, because we know that, for example, for NPM1 mutated patients, those patients do very well with ongoing therapy with azacitidine and venetoclax, which is the new standard of care. So you might realistically have a 68-year-old patient who could get CPX 351 up front, who could get 7 and 3 plus gemtuzumab, who could get chemotherapy followed by a transplant, chemotherapy followed by maintenance. That patient could also get azacitidine and venetoclax and get ongoing therapy with that. It's actually kind of complicated to figure out what you would give this patient, and there's no possible way that we are going to have randomized trials to answer all of the questions that I just gave you. Furthermore, the practical management of any therapy goes into the ultimate outcomes and the ultimate success and overall survival. If you look here at azacitidine and venetoclax, which could be offered to a patient in an ongoing manner, you've got to do things to this therapy. You have to change the dose. You have to change the schedule. You have to watch for cytopenias in the long-term setting. So for my 68-year-old patient that I tell you, how's the world going to do this? Is the world going to transplant that patient or give ongoing cycles of something like azacitidine and venetoclax? We don't really know. And I think that all of us would be very curious to see what is actually happening to all of these patients who might be eligible for actually different forms of both induction and post-remission therapy. What's happening to them in the real world? This just came out a minute ago in Blood 2023, a so-called international real-world cohort of 76 patients who are NPM1 mutated patients who were treated with an hypomethylating agent or low-dose cytarabine plus venetoclax, and 58% of them got MRD negativity. They did a little experiment with, I think, 22 patients who ended up stopping treatment when they were MRD negative, and those patients had some prolonged survival. This is 78 patients. It's in patients who were treated in England and in Australia, but it's giving us a glimpse of how are we going to figure out for our patients which therapy to get, how to measure their MRD. These are patients with PCR testing, and how might we be stopping and starting patients on post-remission therapy. These types of real-world data are going to offer us clues that we need to actually function in clinic, because the randomized trials just aren't going to happen. I hope this gives you a taste of what we want for real-world data. I hope somebody out there has a great idea about how we can have some giant REDCap or other database where we could all actually put in data and look for the answers to these burning questions in AML, and I'm happy to take any questions from the audience.